This isn't just a government thing. There are many Americans who have long celebrated business and our type of capitalism, and they once said they trusted business in general. Then came that financial crisis driven by business and Wall Street's products and schemes.
The country's second biggest subprime mortgage lender was teetering on the brink of bankruptcy today.
He has no idea how bad it is out there. He has no idea. He has no idea. A record number of home foreclosures.
No Wall Street prosecutions, no Wall Street bankers went to jail after something that I think we can all agree, sort of turned this country upside down.
Zoom, zoom, zoom. Hello.
Hello.
Hey there.
Wow, this is what is AI note taker?
Oh, it's an AI, I guess, what do you call it? Like a language system, I guess, wherever you want to think of it, taking notes on our meeting. And then it should spit back either a summary, follow-up points, and it can do a number of things. So I have, people's note takers will join the meeting. Maybe my assistants will come in too if he can't make it. It's generally a good thing to have also for just like nothing that was said can't be misconstrued. We could go back and look at the record, like courtroom. I think for mental health, it's very important.
Oh, that's super cool. Thank you. Thank you for introducing that.
Sure, sure. So what brings us together today?
Yeah, so hi, I'm Jiwon. I'm the person who contacted you.
Okay.
I'm currently a postdoc at Stanford in psychology.
Okay.
Not therapy psychology. I'm more of like vision scientist right now, but
Yeah. You talk
and
about
in
sure. What would be the difference between those two things? Walk me through it.
So right now, like my research for my research, I look into the eye tracking data and try to build a computational model for like the estimating the next eye movement.
I see. Is that how you found me? Because I wrote an article about that.
Actually, no, but that is really awesome that you wrote about an article
Are
about
you
that.
kidding me? Well, no, I wrote about eye movements and mental health and mental illness and how recognition can detect that, or at least it should if it's not. And we can use it as I wrote about it. Of course I did.
Oh.
Yeah. Well, I blogged about it and I noticed it was reblogged somewhere else in some site. And I said, oh, well, it was okay, because there's a lot there. And what I'll do is if you could maybe, I don't know, yeah, I'll do it for you. I'm just going to go to my blog and pull it up for a second. Well, I just tell you that my general basis reason why I'm talking about it for just this moment is people don't think that, mental illness is visible, but, your eye movements, deviations, or different patterns that someone mentally ill finds themselves moving their eyes, very much a thing. And I can look at people in their eyes, especially the eyes,
Yeah.
and know
Yeah.
that someone is sick. Okay.
Yeah.
So anyway, back to what you were saying.
Yeah, we do recognize there is like EMDR. Is that a type of, therapy,
That's not what I
therapist?
mean. That's not
Oh,
what I
it's
mean.
not. It's
EMDR,
not.
EMDR is a type of therapy that therapists use eye movement, right? Eye movement. But I'm talking specifically when someone is mentally ill, I can look at them in their eyes and tell based on the way they're looking around if they're sick or not. That's what I'm
Uh-huh.
saying.
I see.
Not treatment, just detection. Okay.
I see. I
What I wrote
see.
about
Yeah.
was how these systems can be used to detect people that are sick on the streets and get them, maybe trigger something or their provider to say, hey, look, this person should be called in. Maybe they're not doing so well. You know what I mean? As like an early intervention sort of thing
Right, right.
on a
Yeah.
public safety, public
Yeah, that's so
health level.
cool. Yeah.
Okay, yeah. Sorry.
Yeah. And well, getting back to the point,
Yes,
like,
yes,
I
yes,
was
please.
introducing myself.
Sure, sure.
So
Yes.
yeah, so I'm, for the daytime, I'm a postdoc at Stanford, and for the other side, for the other side, other hat that I have is so I and G and is we are all, taking this course called startup garage, where the aim is like you actually, bring a new business idea and like initiate a new startup. So we have been working on like building a tool that mental health therapists can use. So that's why I reached out to you. And
Great.
maybe Angie and Insaf also can introduce themselves.
Hi, Max. I'm Angie. I'm a fifth year PhD student in psychology, also not a clinical type. I study how people decide what to look at and when to stop looking from a computational and developmental perspective.
Oh,
So I actually spend more time coding than like interacting with people.
and
Yeah, I'm just taking this startup garage with Jiwan and Insab, and it's been really fun.
sure it is. I'm sure it is. Awesome.
Hi, my name is Insub. I'm also doing my PhD in psychology. I do, I don't also do clinical psych. It's more about neuroscience.
Oh, science, great, fantastic, awesome.
Nice
Thanks.
to meet you.
Good. Good work.
So looks like you are a type of person who implements like all these, cutting edge technology to your therapy practices. You're using AI note taking and you know about these eye tracking things. And what else do you use? Like what type of therapy do you practice?
Yeah,
And yeah,
I
can you tell me?
practice
Yeah.
anything and everything I can get my hands on. I just learn about therapy, different therapies from, I started out, I guess, on the level of professional education, evidence-based practice. And
Hmm.
I came at it from a community health perspective because I started off doing ACT team, on an ACT team. I started community treatment, some local treatment, interdisciplinary treatment out in the community. You call it hospital without walls, that sort of thing. That was when that was on the rise, and I was an intern in upstate New York, traveling across spanning two counties. Down here where I am in Westchester, it's a lot more. There's like 5 teams for this county. Where I was, there was 1 team for like 4 counties. So you spent most of your time on the road, but you were thinking a lot about your cases, and they were very, very, at least we're on the very high level, or at least high profile for the county in terms of mental health. So I've always been, very much had my feet in my hands in the trenches that way, looking at things, not just like, in the room, but really how's it work in people's lives? How does mental illness operate and function in their lives? How they impact it on an everyday level, not just when they come in and report symptoms. Because I think if therapists sort of work with just the symptoms when they're coming into session, reporting it in this therapy office, they don't get a good perspective on what's really happening in their lives. And if they don't get that, they don't know how to treat the person, right? They don't know how to help them. It's all very abstract. It's surface. It's definitely not going to get to the root of the issue. And when you're in people's homes and we're out there with them walking around, and then maybe I don't do that today, but at least I think about it that way, and I'm able to talk to them in that way. Also, I'm very open about my lived experience. I have a schizophrenia diagnosis. When I was in college in my last semester, I had a full-blown, first episode psychosis. So I lived with schizophrenia, and I wasn't even sure if I had graduated. Thank God I did. When I got back to the state hospital because I was so sick, my degree was there. And within about a year of practice and recovery, I was back in grad school, the same school, and then started practicing after I got my MSW very quickly. And I, rose through the ranks and sort of was very good at what I did because I knew what it was like on sort of a lot of levels, as I'm trying to say. And, I had to sort of go my own way after a while because when you disclose you're a peer, and have lived experience, you sort of get blacklisted in a lot of places. People don't look at you the same way. I knew it was going to happen. I would hear people talking about clients, right? And we still do. This was about 10, 15 years ago. And, I make my own way. But I knew how to do that because one, I was a professional, and also because, if you want to really help people, you sort of do have to do it your own way. You can't do it in an agency. You can't do it if you have to stay in your lane and all that stuff. So I love what I do. I can do anything I want. I do everything I want. And this is my company, and we do great work. The county won't fund private practices that peers paying for it out of our own coffers because we know it's important. And two, we know that that's how people heal. And maybe we'll create a way for the county to do it on our level. You roll that out as a thing later on. So you have to believe in what you do and know that if you make the right decision today, tomorrow people will look back on that and say you did the right thing. You have to replicate that and make it a thing. So that's why I do what I did. That's a little bit of who I am.
Mm-hmm. So I wanted to more touch upon your practical side of, doing your practices. Like I'm wondering, like, when you see your therapy clients, like, do you usually give out them homework, or like what type of, therapy do you do?
Sure. Well, I mean, it's all talking with them, speaking with them.
Talking with
But
them.
it's, yeah, I mean, I can do a number of things. I mean, in terms of like what we're talking about, how I approach that,
Mm-hmm.
usually I start, okay, so this is how I'll start off, usually with everyone. So, how's your week? Right? People, will answer a different way, right?
Yeah.
Depending on what's going on with them, who they are. Once I got this is extreme, okay? Once I got, what do you mean what I do? Woke up, washed my face, washed my ass. Fuck you. And they hung up. And that was it. Last I ever heard from them. Very brief, very quick. That was session 2. Uh, but other than that, usually people are very friendly. They will say, "Oh, how was my weekend? Did this, I did that." Then when we start to talk about the events in their lives and what they do, where they go, or we'll talk about maybe issues they ran into, maybe some of their like goals that were met or not met, family they spoke with, just conversation about what's going on in their life. It's about what they report is what's important. So if
Mm-hmm.
what they're telling you, what they select and say, this is important to me, that's a very important thing to talk about. So I don't usually like try to ask for something so specific
Mm-hmm.
where that'll get ruled out or they won't tell me. I kind of keep it open-ended. Whatever they say, I'll dig deeper. And depending on the content, then also select a certain modality. Okay. So,
I
like,
see.
if they're talking about an irrational belief, maybe something I think is irrational, something that sounds a little strange, I'll start to bring in that sort of therapy that'll deal with that. But if the conversation shifts or I realize it's not so rational, there's a real valid reason for thinking that, I'll switch. Any good clinician knows which scalpel or retractor. They know how to switch very quickly, and they know if they're going, coming into as with the astronauts, we're coming into shallow. We're gonna, skip off the atmosphere. We have to know as clinicians, are we being too invasive? Like are they like reacting? So I really try to use my judgment and read on the person before I, select a certain therapy. But I also will try to pivot the best I can and hopefully at the end of the session land in the right area, right?
I
Feeling
see.
better, feeling better.
Right. So previously you mentioned about that you do some evidence-based therapy too.
I missed the second word. I'm sorry.
Oh, evidence-based
Yes, of course.
therapy.
Yes.
And I wonder, like, how often do you implement that technique or method? And because like that's very relevant to what we are pursuing. So
Everything is evidence-based that I do. Everything is evidence-based. There are a lot of different evidence-based therapies. So,
I see.
or evidence-informed, anything that is bringing in something more of a scientific way of approaching the situation. That's evidence-based. And also even things that are more peer, like, let's just talk as equals. Well, that's an evidence-based treatment because you're using, peer work to get that trust buy-in to then do the therapy you want to do. That's going to get you that scientific data, whatever it is.
Mhm.
So everything is definitely evidence-based, whether it's CBT or something specific, trauma-informed CBT, everything is. It's just that
Right.
uh,
Okay.
I try not to have it feel that way for the people that I'm working with. They don't want a robot, but I still have to be a scientist at the end of the day. You know what I'm saying? So it's all about getting the right information and conducting yourself in a way that feels human, but you're being a clinician about it, if you will. So yeah.
So I'd like to show you our prototype, which is like a paper and pencil version,
I did.
a little bit nicer than paper and pencil
Okay.
version. But like basically the idea is that we wanted to make a tool that therapists and clients can be connected between sessions.
connected. What was that part?
between sessions. So basically, like clients only see a therapist only once or twice a week, right? Or once a week or once in 2 weeks, right?
Yeah.
And we believe that therapy has to be more of like continued support system rather
No,
than like
I
occasional
disagree.
check-ins.
I disagree
Yeah.
right away. Right away. And I'm gonna hear you out and hear your whole presentation, but right away I'm like, uh-oh. Just like you know. I know it's really quick. You didn't really say much, but but even for what you said, tell me, and I'm really curious to hear why. So from now, while you're presenting, I really am listening very closely. So you have my full attention.
Wait, I didn't hear you. Sorry, but
Oh no,
are you saying that this is not a good idea
no, it's not a
or
good idea. But I
okay?
really want to hear your presentation, and I'm very interested. I want to know what you're going to say. I'm not like dismissing you or anything. I'm just saying right
Sure.
away, I'm like red flag in my head.
Okay.
But
I
keep
want to hear
going.
your red
No,
flag
not yet.
Okay,
No,
sure.
not yet.
Sounds good. Okay, I'll just share my
Yeah, this will be
screen then.
fun. This is fun.
So this is like our like design that we created. So basically, like this is the app that on the
Amazing.
client side, what they see.
Oh,
So
cool. I'm gonna zoom in. This is really
for example, like the client or the therapist, maybe I can show you this.
yeah. Sure. Walk me through
So
it.
maybe yeah. I mean, this is my first time like, working
Is
with
it?
this,
Okay. Okay.
images. So I've been
Okay.
like a little bit like,
Oh, I'm
confused, but
sorry.
like,
No, 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 no.
yeah,
Take your time. But I'm just gonna say,
sure.
give me the full. Don't hold back on it.
Okay. So basically our idea is that a lot of therapists give their clients a lot of homework, like including CBT or some cognitive intervention.
Yeah.
But usually it's done through like, Google Docs, or you also use like Google spreadsheet,
Right. Very
which is
correct.
not HIPAA compliant. So it's
Right.
like, they like a problem and it's not safe.
Okay.
Also, a lot of
Sure.
them like are not good at like organizing those documents in one site.
Right.
And usually like even though like they gather the data, they don't know how to use it, or they can't really, have a bandwidth to keep it,
They
manage it
forget.
for a
Yeah.
like longitudinal term. So this is the app to solve that problem.
Okay.
So
Cool.
basically, like therapists can assign their clients different like homeworks on their app,
Right.
and you can also use, I don't know, this is one idea, like nowadays, like still like even with the like technologies development, like still like they do pencil and paper type of the cognitive
Sure.
interventions.
Sure.
And our idea is that like we can turn it into a conversation with a chatbot, so that they can the finalized output after the conversation would be, we return everything back to the original format, so that like clients, sorry, so that therapists can look into it, or like readable. And the clients also can see like their daily progresses or other like lifestyle related logs.
Nice.
And this is therapist view. So basically they can assign their homework and keep track of their progresses and check in, like remotely check in, like how their clients are doing.
Very interesting.
So now tell me what was your red
That's
flag
a full
and
presentation. So
Mhm.
you said you wouldn't hold back.
Yeah, this is it.
Okay, cool. All right. So where to start? Okay.
Can I turn off my screen sharing, or do you need it?
No, I
Or
leave this page. Just first of all,
okay,
hey,
sure.
it's just me. Listen. Okay, so this is what I'm thinking. Just list off the top of my head. So the premise that it's the intensity or frequency of therapy, all right, that a patient isn't making progress is most of the time not true. This is why, okay? As long as they're not like off our map of the schedule, if you will, right? If they're meeting consistently for their scheduled appointments and prescribed frequency of treatment, okay? And they're not like disappearing, whatever, they're consistent with it. Then then I think one that's great, okay? And they're usually not going to make a whole lot more progress if they sit for another session, okay? Um, you know, like let's say Monday, Wednesday, Friday. If they just met Wednesday, maybe Friday, they make the same progress. I can almost guarantee you rate of progress, rate of recovery, as if they were meeting for 3. Now, your intersession thing, okay? The intersessions where you homework and assign homework and keeping track of it. You're 100% right that there's a shitty way of doing that right now. These Google Docs, all that stuff. 100% right. I'm guilty of the same faux pas. I'll sign something, I won't follow up. It's not HIPAA. I'm attaching stuff to an email. That's not good. That's not kosher. That's got to change. But I think that if they're meeting consistently for their sessions, okay, their scheduled sessions, whether or not they complete the homework, I don't know. I don't know if that's going to be the boost we're looking for out there in terms of people making those gains that they weren't. So you're saying here that it's the homework, not doing the homework piece, the practice between sessions where people are losing progress. Is that what you're saying? Is that a good way of like rephrasing it and like simplifying it? That the lack of homework, consistent homework between sessions is why people aren't making progress or sustaining their progress.
Well, I'm not appreciating the effect of therapy, the main therapy session, but I do believe that and also there are some studies which supports the idea that if you do the homework like
Yeah.
that boost up or like speed up or make generally like, turns in better outcomes.
Yeah, if you do homework, period, right? If you practice, but the idea is that really isn't really a specific app, I think, that needs to do that and track it, okay? Because people need to practice all the time. I practice my own recovery every day, every hour of every day. I'm gonna make a mindful, intentional decision to work on my recovery, to make a healthy decision. Okay. That's just for me. And if like healthy decision for everybody, if they're more mindful every moment of every day,
Yeah.
make a healthy decision, okay, and make a healthy choice, that's going to help them, no doubt, recover it. I don't think an app needs to tell you, that's just, well, the app is not going to tell you, maybe it will remind you, but I think your big thing here is you're tracking progress. That's a big thing. We need to track progress, and we use measures to track it. And that's not the best now. I wrote an article about that, how like we have all these measures now in EHR systems that are tracking progress better, and we need to continue to track progress. How is progress measured? That's a big thing. Because when you know how it's measured and how you're thinking about it, then you'll be able to make different treatment decisions as a therapist and say, I need to do that modality or that modality now, like, But the thing is, in terms of clients practicing a skill, they don't need this special app to know you always need to be practicing, right? But the measuring part is important. And I once went to a thing, it was called it was like 15 years ago, but it was very, very funny. It was a whole thing about how do therapists measure progress, this ongoing question that I'm talking about. And they devised this crazy thing, sort of similar to what you're doing, about how to measure progress, okay? And it was effective measuring and adapting practice, right? Because the idea is we're going to adapt our practice based on what the measures are and what it's spitting out, the read, okay, what you have here, these bar graphs or whatever. And I said to myself, during that presentation, none of these therapists in this room, you think Belinda, 50-something, is going to take the time to really do this the right way and learn this in her practice? By the time she does, is it really going to teach her, after she does all this stuff, sitting and doing and computing, how to adapt her practice? She doesn't know enough about therapy, period, to adapt her practice. So, it's also the therapist's skills, okay? Because they can have a great read on how someone's doing based on these numbers that they see, these numbers, right? But they don't know how to adapt their practice. Belinda only had 2 years of learning about therapy. Maybe she took a couple extra webinars. She's an LMSW. She's not a seasoned LCSW. She doesn't know if she gets a 7 or a 9 on a score chart, what to do in session when the client does whatever. That's my point. It's more about the
Yeah.
skill level of the therapist, not so much these
I
measures.
hear you.
Yeah.
Yeah, so I hear you. I think that's why we came to you.
Oh,
So what is your way to measure the progress?
that is very specific to the client and the therapist. So whatever you make up and build, okay, needs to be one understood as this is specific to this person. The therapist has to realize whatever they're looking at, these numbers, a 9 here for this client is different than an 8 over here, because you're measuring and thinking about these people in different ways. We get these numbers and we sort of like generalize and make these these things that applies to everybody. But whatever the person's reading on the screen has to understand that, okay, it's going up. Yeah, because she's been reporting this and doing this. So like how high a slope or whatever the number is not as important as the trend. It's about direction. Okay. Like, is a person getting better or worse? Are they doing something more or less of behavior? Okay.
Yeah.
Not so much a 30 to a 5. They have to know that up means more suicidal ideation. You know what I mean?
Yeah, yeah,
And
yeah.
like, you know what
I
I mean?
mean, these
People
are
get
the,
yeah.
sorry to cut you,
No,
sorry.
no, no, no. I
I
talk.
didn't want to
I
interrupt
talk. I
you.
know, I know,
I
I
mean,
know.
these are numbers not directly showing whether a person's, emotion or mood is like N score. We are not like selling like that. We are
Some
just
therapists
showing.
who think that though, they'll get so into it, they don't understand that. Oh, they'll say, oh, they'll get really obsessed about the numbers and not so much what the numbers mean, you know, and or what to do when they see a number like that, how they actually adapt their practice. Because this doesn't tell you anything about once you get these numbers,
Mhm.
what to do with your technique, does it?
Well, these aren't, yeah, I mean, as I said, like these are not directly show like
No,
whether the
sure.
person.
But if I'm a therapist, I see this data, how do I know what to do in session to adapt my practice once I get these numbers? Does your thing do that yet?
No, I'm just curious
Okay.
about how would you use this if you see the declining numbers?
I would have to know what the numbers mean. So give me an example, okay? Give me an example of a trend or something or some data point where I could tell you then what I would do.
For example, let's say your client is having um episodes at night more than usual,
Okay?
and the trend is going up.
The trend is going up.
Yeah.
And the trend is going up when it's whatever type of graph it is or whatever, it's
Yeah.
going up and it's bad, right? It's bad.
Hmm.
Okay, so first I would want to know how bad. And I would like, for example, like a lot of things will give you like in terms of self-harm or harm to others, very important, right? It's a harm piece.
Uh-huh.
The danger, right? Piece. So like it's broken down in a lot of different like things that do these charts will break it down in a certain way. And
Hmm.
and like for example, all right, if I go to like so my EHR, okay, I use therapy now. So to give you an example, and then trust me, this will help. Because so for example, I'm doing a note progress note. Okay, so all progress notes now they have a risk assessment. And then you can either check off and deny everything, or you have to identify an area of risk, the level of risk, intent to act, plan to act, means to act. Then the risk factors, the protective factors. Okay. So let's say the trend's going up and it's bad. And I would probably want to read out that assesses like intent level, plan level, means to act level. So like if you do have numbers and do have these graphs, they really should align to what's important clinically, right? So like
Hmm.
the intent level, the plan level. And let's say once I get a good readout of that, I know, okay, well, they've protective factor, they love God.
Okay.
So listen, they love God, okay? So
Hmm.
if you've been to church this week, or maybe I'll hear religious idea, like I'm the Lord's anointed one. Oh yeah. So how's it feeling going to church lately? Is it feeling a little like adversarial, feeling a little involved? Maybe they're so wrapped up in their religious delusion that they're afraid to talk to their pastor, something they do every week, whatever it is. So you want to like a protective thing, if it's church or God or maybe it's family. How's mom? Right? And I'll talk to them about their family and their supports. I'll make a focus and purpose to hone in on that area of their life. So I want to get a good understanding of what's going on there in that week. So I can maybe encourage them to in some way talk to that person more. Maybe mom's not trying to kill you, sort of thing. Does that make sense?
Yeah.
And that's
So
just protective factors. There's a million things that you can adapt your practice based on what's important politically and where the trends are.
So what you're trying to say is the measures that are clinical matters to you the most, and other measurements are not that much of a help.
I think all information is good information, because any good therapist is going to take anything they hear and get it and like start there, move into another area. But I guess what I'm trying to say is, whatever is being measured, make it clinical, important clinically. So like the harm piece, it broke it down to very specific areas, right?
Mhm.
As opposed to just a general thing. And based on maybe a clinician understanding up or down, okay, let's talk about whatever it is, the protective factor that might lead to less self-harm or more likelihood that the person's going to stay safe from week to week. And they'll know maybe titrate up a specific type of therapy that's going to work on a limiting belief that might increase the self-harm. You know what I mean? So like there are ways of like, I guess the point is whatever is being read should also tell the therapist what to lean on in therapy, maybe direct them, talk about this or that, because based on these numbers and their history, that might be a good place to start in order to get, a better read or a safety plan in place.
Mhm. So what you're suggesting is just presenting the numbers is not enough. Some kind of like insights, actionable insights are like needed, or
Yeah, definitely. Just numbers is like nothing. It's not a lot. That's not a lot. It's basically a traffic signal. Therapist needs to know what to do with that signal. Go ahead, stop. Like I'm gonna crash. Like don't say that. To the client. They're like, like you're giving us a traffic signal. We need to know what to do with those lights. You keep driving. You stop. You make a turn. It's very important. Therapists don't have great skill sets. They're not all Max Guttmans. So they need to know what to do. I know what to do because I've been doing this a long time. A lot of therapists haven't been doing it a long time, or they're just shitty therapists and they don't know how to pivot. It's all about adapting your practice. They need instructions on how to do that.
so only like seasoned professionals would know how to use these numbers, you're saying, or is it?
Maybe probably not.
I thought the whole point of getting licensed,
No.
getting all these
Yeah,
education was
don't
to
be
give you
naive.
insights on how to do therapy, basically. That's why we try to give numbers so they can do the interpretation and come up with like next
In any
treatment plans and all
profession,
that.
in any profession, not just mental health or therapy, there are a lot of people. I think we think too much of people and they're knowing what to do and being knowledgeable, right? I mean, even at the level of retail, you work in this store, you don't know what aisle I'm supposed to go to buy that. You don't know if it's in stock or not. You know how to use that inventory thing. That's retail. I mean, I think doctors, maybe surgeons or astronauts, they have to be very precise because, man, their life's on the line. They can't make a mistake. You know what I mean? But professions, most of us, we can make mistakes. And when people can make mistakes, they get lazy. And when, they get lazy, people get hurt. Unfortunately, people, I think they just, they're lazy and, or, they don't, it doesn't matter if they don't make that call or this or that, because it's not their ass. It's client. And again, how much do we really care about other people? There's a lot of reasons. I just think that like, a license doesn't say much. It means you know how to pass a test and you have a certain number of contact hours and education. It doesn't mean you know what you're doing in the room. It doesn't mean you know how to help people. That's not something you learn on taking, studying for an exam. That's a skill. That's a talent that I think a lot of people, it's natural. Just helpers or they're people. Some people aren't.
Maybe just kind of a follow-up question. So I'm
Yes.
wondering if during your practice you have felt like you wish that you know what's going on in your client's life more frequently, or maybe a different way to frame this question. What are some information that you wish you could collect from the clients between the sessions that
Great
could provide more
questions.
insights?
Fabulous questions. What they're doing with their free time, how they spend their days, like, are they getting stuff done? Are they running into unnecessary unnecessary like setbacks? Why the setback? Was it cognitive? Like, is there a reason why there was a setback? What didn't go well? And then how were they able to get back course correct? That sort of thing. Or emotionally, are they getting upset for no reason? Are they getting too upset, less upset? Are they detached? I like to collect questions that really look at people's affective regulation, their or their thinking. Generally, aside from their emotions and the way they think, a lot of other stuff is like personality. They call it the personality stuff, and that's not something that's going to be really addressed in a single session. You know what I mean? That's deep. And if it's and trauma, well, we got to know, like that's something that is also like, we're going to talk about trauma that day or something, unless it's a trigger where there's reason why they'll flash back and tell you anyway. If they're triggered, they'll come in. I got to talk about this. But usually trauma, I don't need to know that from moment to moment. It's really their emotions and their thinking. It's very important. Very important.
Got it. So maybe, for example, if you could have access, you could ask, almost like force your patient to keep a journal and have some life updates into what's going on in your life. Those qualitative insights would be more helpful than a quantitative number.
Yes, yes. Yeah, sure, absolutely. I can look at on a week, just a week readout to emotional, less emotional. You know what I mean? Or conversation points about it that might indicate what's going on. Absolutely, absolutely.
So what would be your like ideal software that is missing
Oh, well,
out there?
I think you folks are much better. I'm sure you know a lot more about software than I do. I just know about certain EHR systems that are using these measures and aren't. They give you a number, but again, these numbers aren't very helpful unless you spend a lot of time on doing a progress note or whatever on a particular day. Probably not looking at the numbers anyway. You want to get your notes, submit, let's get paid. But the thing is, the software, whatever it is, it has to be HIPAA compliant. And I guess the faster the clinician looks at it and knows what's going on with those realms that we talked about, probably the better. Don't make it super involved. Marianne, age 60, wants to get home to her kids and do her notes. She's not going to spend time reading the charts and looking through things, right? She barely knows how to use a computer. Hey, Ross, can you help me? She needed help just to turn it on. Or, you know what I mean? She's not reading high level, information about a client on a particular day, especially not multiple times a week. Maybe during a treatment plan review, there should be some consideration there. With projected plan over the next month or two, then sure, some time and consideration needs to go into that. But on a day-to-day basis, we're busy putting out fires.
So what kind of functionality do you use the most within the therapy notes? Billing? Is it scheduling or is it
Scheduling,
yeah.
huge, huge. Remember I talked about clients falling off the radar and like not being on my schedule? We need to know who's not on your schedule. So you need to look at, this is very big, write this down. Active caseload, okay? That needs to be defined. Who's active? Does that mean they're meeting consistently? Or does that mean they're just assigned to you? Active should mean meeting regularly for a prescribed period of treatment. Who's ever not on the schedule and that conflicts, an incongruency, flag, flag, flag. Go in after that person. Where are they? What are they doing? Why aren't they on my schedule? You see what I'm saying?
Mhm.
There's nothing here that does that. I'd hire an admin person to do that. Shame on therapy notes.
I see. Okay. So yeah, we'll definitely take that into consideration when you're trying to
Huge,
make something. Yeah.
huge. They call falling through the cracks in treatment. I can't let that happen to my people, but there's nothing in place that allows me to check on that. So I
Mhm.
had to create my own way, or I'll have a person do it. Hopefully, you folks will build something and call it the mindful living, whatever gadget. Maybe name it that. I'd be obliged.
Got it. So how much do you pay for the therapy note?
The subscription,
Yeah.
let's say 100 something. And if you have multiple clinicians, another 10 for each. Like,
Uh-huh.
it's graduated that way.
Got it.
Yeah.
Do you spend any other money on different kind of softwares for your therapy practice?
Yeah, a little bit. Yeah.
Can I ask what they are?
Just the AI note taker now.
Okay. So you use the AI note taker to like get the notes
Yeah,
and
I actually very recently
Mhm.
used therapy notes to create a waiver or whatever that allowing me to use an AI note taker that's not a part of the system. All my
Uh-huh.
clients have signed off that I'm allowed to use an AI note taker because that's what we do at Mindful Living.
Mm. So it save out of your time to come up with like treatment plans and all that.
Doesn't save much time. And honestly, it's just very interesting. It will spit out these homework assignments in a very individualized way because they're
Uh-huh.
based on our conversation that day and not, like you said, me fumbling with a Word doc or whatever and creating something myself. Boom, this is exactly what we were doing. This is what we were talking about. Here's your homework assignment. Bam. But other than that, it's just a fancy way of doing things. And I appreciate that because I'm a fancy guy. I like to do things that way. But
Mm.
I think that you know, any cowboy can, as long as they have an understanding of what to do, can go out and do it without that equipment. Sure, you know.
Uh-huh. So do you plan to keep using these kind of AI note-taking tools or
Until I did some implant up here that allows me to do it myself. Yeah, sure. I'll use any device or any technology I can. I'm a prosumer. I bring in technology into the picture. And I produce and consume. And I use
Mhm.
technology in that process. Very important. We need to always use technology. Come on. Right? No? Maybe.
Yeah. Because you said you don't gain much out of the AI note-taking tool.
Not much. I don't.
Okay.
People do. Not everyone knows what I know, and not everyone brings in a certain you like, for example, some people I came into this with a whole lot of like, I'm already looking at certain things.
Mhm.
Most people aren't. And that's gonna point them there, teach them how to do it, give a way of doing it. I know how to write a progress note.
Okay.
I always did. I wrote all my books I wrote before all this stuff. So like, while it might polish some stuff or show me other things, they got it. I came in with a skill set. I guess
Mhm.
people that are younger than me and even younger than that might not. So they'll probably be very reliant on these things. I'm not, but
Okay.
I appreciate at this point, I always appreciate another having a conversation, but I think the younger folks coming up, it's gonna be very important that they use these things because they're not looking for the right things.
Got it. Yeah, thank you so much for sharing. Yeah, I also want to be mindful of time. Do you have any
Oh yeah,
like last questions for
nothing.
us?
This was very fun. I had a lot of fun. I hope this was like um, you know, something that was productive or you'll benefit from. But I'm very happy to hear also that you folks are working on these things and thinking about these things because no one was and no one has been, and thank I'm very thankful to hear that you folks are.
Yeah, yeah, thank you so much for sharing. We learned a lot. Hopefully we get to
Yeah.
implement what you said.
And make a difference, right?
Uh-huh. Yes, of course.
Of course. Yeah. Good luck, okay? Let me
Okay,
know how it
thank you.
goes. I'd love to hear an update when all this is said and done. What happened?
Uh-huh.
Please.
Okay.
All right. Thank you so much.
Take
Thank
care,
you.
okay?
Okay,
Bye.
bye.
Take
Bye.
care.